Bismillahir Rahmanir Rahim. We will start with quote of the day. Ramadan is the best time to make or break a habit. Monitoring and surveillance. I am Dr. Taimia Ayub and I will be presenting this topic under the supervision of Professor Dr. Saira Afzal, Dean Institute of Public Health, Lahore. This is the outline of today's lecture. We will start with the importance of monitoring, key concepts and definitions, different frameworks and indicator, how these are being used in Pakistan. Then we will go through data quality, governance, ethics, and dashboards, and followed by recent advances. And then we will do the same for the surveillance. These are the learning objectives of today's class. So we will start with the key definitions. What is monitoring? Monitoring is the routine, systematic tracking of program inputs, activities, outputs, and short term outcomes to guide program management. Then we have surveillance, which is an ongoing systematic collection, analysis, interpretation, and dissemination of health related data for public health action, emphasis on detection and response. Then we have evaluation, which is the periodic assessment of the relevance, effectiveness, and impact of an intervention, usually summative. So, this is a brief comparison between surveillance, monitoring, and evaluation. So, surveillance is a continuous process with its frequency is continuous. Monitoring is routine process and evaluation is periodic. Purpose of surveillance is early detection. For monitoring is the tracking of performance, and for the evaluation, the main purpose is to assess impact. Similarly, in cases of output, surveillance outputs are in forms of alerts and trend. For monitoring, the outputs are in forms of performance reports, and for evaluation, the effectiveness judgment is done. So, surveillance is an event detection focused, monitoring tracks program performance, and evaluation measures long term impact. Let's start with monitoring. Monitoring isn't just about counting, it's about the flow. So, for monitoring, we have a logic model which is about the indicator hierarchy. It has inputs. Inputs are the resources, which can be human resources, funds, vaccines, etc. Then we have processes, which are the actual activities like trainings, logistics, cold chain maintenance, etc. Then we have outputs, which are the immediate results. Number of children vaccinated. Will be the output. Then we have outcomes, which are the intermediate results, increased immunization coverage. Then we have impact, long term results, reduced infant mortality rate, for example. Monitoring primarily focuses on input, processes, and outputs. And evaluation focuses usually on outcomes and impact. So, this is a easy way to differentiate between monitoring and evaluation. So this is the flow which usually is going in cases of the programs. Input, we have activities, then outputs, outcomes, and impact. So there are different types of indicator. For example, for input, there are different indicator, process, output, outcome, impact. Every level has their own indicator. For them, the usually the criteria which is used is SMART criteria, which is specific, measurable, achievable, relevant, and time bound. So this is a small summary diagram to explain monitoring in public health. So in public health, basically monitoring's main function is to put data into action, is to assess data, then inform, and then respond. So for that, the most important is first step is the data collection through health records, surveys, surveillance, and gathering information. Then we have to make different indicator which should be relevant, like mortality rate, immunization coverage, disease incidence, and so on. So it in this way we are measuring health outcomes. Then we respond according to the data we know by interventions, resource allocation, policy change. This means taking action. Then we have evaluation at the end, which assess the impact, data quality check, and improving, which leads all to improving program. And then analysis is done on the trends and patterns, risk assessment, identifying problem. So all these are ongoing process and they are interlinked with each other, and everything goes back to the it contributes to the monitoring. So for monitoring, there are different global frameworks. For example, sustainable developmental goals indicators are relevant to health. In case of WHO frameworks, we have public health surveillance guidance, primary healthcare measurement framework, and for donor monitoring and evaluation frameworks, we have UNICEF, Global Fund, different frameworks. So, for national context, Pakistan's health information structure is arranged in this way that there are multiple components. There is facility reporting systems, vertical program, which are using their HMIS system. Then we have disease surveillance or E1 system, logistics, stock systems, civil registration, and vital statistics. Then we have national HIS assessment and recommended roadmap for strengthening interoperability. In case of Punjab, Punjab is currently using DHIS2 and provincial HMIS or health TMS HIS2 apps for facility reporting and dashboards. For example, health and population department portals are there, monitoring and evaluation assistant visits are there, and reporting. Punjab has active DHIS2 implementations and mobile apps to collect facility level data and support supervision. These are examples of national strengthening. Then we have core indicators to monitor. For example, maternal and child health, ANC 4 plus coverage, institutional delivery rate, neonatal mortality rate. For communicable diseases, we have weekly incidence of notifiable diseases, test positivity, case fatality ratio. For NCTs, there are screening coverage for hypertension or diabetes, treatment initiation, BP control rates. Similarly, for health system, stock out days for essential medicines, health workforce attendance, or bed occupancy rates. There are different data sources and frequency. So, one of them is routine health information system with the weekly or monthly facility reports. Then we have disease surveillance systems with daily or weekly events. Then we have surveys like DHS or for periodic benchmarks, which are done every 3 to 5 years. Facility assessments and special studies are done on ad hoc basis. Administrative and logistic data, laboratory information system, and CRVS, Sentinel sites, and community-based reporting. So data quality dimensions data should always be complete, should be collected at time, accurate, valid, consistent, and there should be data integrity. Data validation rules in DHIS2, routine data quality assessment, lot quality assurance sampling, and supervisory checks with feedback loops. Architecture and interoperability. For that, standards are unique facility identifiers, HL7 FHIR, where applicable, standard indicator metadata. For interoperability, linking of DHIS2 with lab networks, vaccine registries, logistics, and EHR should be done. This is the need of the hour. Visualization and the dashboard, there are different design principles which should be done. You should know your users and decisions they must make. Keep key performance indicator visible. Use drill downs and warning thresholds, which should be more prominent with red color or so on. Ensure mobile responsive dashboards and offline data entry where connectivity is poor. This is a very important point in case of Pakistan's context. Recent advances in digital health and analytics are cloud dashboards, real time analytics, mobile reporting, and integrated outbreak analytics using DHIS2. For AI, artificial intelligence, or for anomaly detection, forecasting outbreaks, syndromic surveillance from non traditional resources, recent literature shows integration of AI and variables and the use of real time analytics in outbreak response. These techniques improve detection and forecasting but require careful validation and governance. In Pakistan, integrated outbreak analytics were used in Pakistan flood response. with DHIS2 integration, province level DHIS2 customization, and mobile apps for supervision and facility reporting are being done. Then comes ethics, privacy, and governance, data protection, anonymization, role based access, and secure transport and storage for protecting the data. In case of governance, data sharing agreement, MOUs between departments, stewardship roles, who owns which data should be made clear. Equity consideration should be done to ensure data collection does not exclude marginalized populations. From data to action, operational pathways. Trigger threshold, for example, if there are more than X number of weekly cases of dengue or typhoid or measles, the rapid response team should become activated and local control measures should be done, which is being done very much in case of dengue in a very proactive way in cases of Punjab, in the province of Punjab. And therefore, we are seeing that dengue is being controlled, monitored, assessed, and all this process is an ongoing process, and it is working very well like a well-oiled machinery in case of dengue particularly. Management dashboards to trigger supervision visits and stock replenishment. Capacity and human resources. Skills are needed, for example, data clerks, data managers, epidemiologists, data scientists, monitoring and evaluation officers, and IT support. Like in Institute of Public Health, we recently had training of data entry operators, which were doing particularly data entry in cases of dengue and other such diseases. So, training priorities should be done to those people who are currently working, which are DHIS2 user training should be done, data quality tools, and basic epidemiology should be taught to them. And then dashboard interpretation and outbreak analytics should be done. This is also being done at Institute of Public Health, particularly for dengue and other diseases like influenza, in collaboration with PITB. Monitoring plan step by step. So, these are some parts of the monitoring plan which can be followed for good quality monitoring and a continuous impact. For example, it starts with defining purpose and audience, then listing of indicator with their definition, then assigning data sources, frequency, and responsible persons, set targets and thresholds, define data quality processes and validation rules, design dashboard and reporting cadence, plan capacity building and SOPs, then budget and procure tools. And this should keep on doing for starting of monitoring. Okay, so this is a small example of a monitoring plan of maternal health with indicators as ANC 4 plus coverage. For this numerator should be the woman with more than or equal to 4 antenatal visits recorded at facility. Denominator should be estimated pregnancies in catchment or registered or number of registered pregnancy. Data source should be facility register, for example, DHIS to monthly upload. Frequency should be monthly. Responsibility should be facility of monitoring and evaluation focal person or and district monitoring and evaluation officer. Then a monthly validation should be done, cross-checking with antenatal care register, and target should be 70% by end year. Common challenges and mitigation strategies. There are fragmentation and parallel reporting, which should be mitigated by harmonized indicators and reduction and duplication. For poor data quality, implement validation rules and supervision with feedback. In cases of limited connectivity, use offline first mobile tools and periodic syncing. Human capacity gaps, stepwise training should be done, and supportive supervision should be provided. For monitoring during emergencies, like in cases of floods or outbreak, rapid need assessment dashboard should be made, syndromic surveillance, sentinel site scaling, and integrated outbreak analytics should be done. Using of predefined emergency indicator and mobile reporting forms can further accelerate the process. For evaluation linkages, when to evaluate, use monitoring signals to decide when to commission evaluation, midterm or endline or operational research. Example triggers like persistent underperformance, unexpected trends, or significant program scale up can also help in deciding when to do evaluations. So again, this was a summary which we began with, and I hope I have covered many all the parts of it relevant to the monitoring. So now we come to another important part of the presentation, which is the surveillance. According to WHO, surveillance is a systematic, ongoing collection, analysis, interpretation, and dissemination of health data for planning, implementation, and evaluation of public health practice. Its key components are continuous, action oriented, and it should be linked to response. So, there are different types of surveillance. Let's start with defining them. We have passive surveillance, which is the routine reporting from facilities, and we have active surveillance, which is health authorities actively seek cases. Then we have sentinel services, which is done at selected sites to collect high quality data. Then we have syndromics and services, symptom based early warning, and then we have event based surveillance based on rumor or media based detection. And finally, we have laboratory based surveillance, which is confirmation focused systems. So, the core functions of surveillance are case detection, registration, confirmation, reporting, data analysis, interpretation, dissemination, and response. Attributes of a good surveillance system according to the CDC framework is simplicity, flexibility, acceptability, sensitivity, predictive value, positive representativeness, timeliness, and stability. So, global surveillance architecture are, for example, WHO has a global influenza surveillance network. Then we have global polio surveillance. These are some of the important examples. Then we have global outbreak alert and response network. In Pakistan, Pakistan uses multi-layer system for its surveillance, starting with National Institute of Health (NIH). Then we have provincial health departments, and then district surveillance units, health facility reporting, and laboratory networks. So these are some of the key surveillance system in Pakistan: integrated disease surveillance and response, early warning alert and response systems, polio surveillance, TB surveillance, HIV surveillance, and DHIS2 based reporting. Some of the challenges which in Pakistan are underreporting from private sectors, laboratory capacity gaps, fragmented vertical program, workforce shortage, and delayed reporting. So, strengthening surveillance in Pakistan, for that, there are some important recommendations which can be followed to lead to better surveillance program in Pakistan. The most important recommendation is the integration of all the vertical programs. Like I mentioned before, that TB program and HIV program, all these are working in silos. So, what should be done is the integration of all these different systems, improving laboratory network, strengthening district epidemiology workforce, improve interoperability, and increasing budget allocation. So, future directions, one of the most important is using AI enhanced surveillance and One Health integration, which is the most important need of the hour, climate linked disease forecasting, wastewater surveillance, and digital disease detection. So, in recent advances, these are some of the advances in WHO. The number one is the enhanced AMR monitoring dashboard by WHO. It was launched on updated global antimicrobial resistance and use surveillance system, which is also known as GLASS dashboard in September 2025, expanding real-time global tracking of AMR and antibiotic use across countries. This boosts comparative monitoring of AMR trends globally, supporting national action plan for antibiotic stewardship. Then we have monkeypox monitoring continues worldwide. Ongoing surveillance of Clade 1 and Clade 2 monkeypox shows sustained detection in many regions, including travel linked cases outside Africa. Global Public Health Network, for example, CDC surveillance system, continue monitoring for local transmission and international spread. Similarly, we have Nipah virus preparedness and surveillance intensification. In Pakistan, has recently expanded Nipah virus surveillance and screening at hospitals and border due to regional concerns with updated cases, reporting protocols, and heightened clinical monitoring. Surveillance include neurological and respiratory symptom tracking, laboratory readiness, and coordination with agriculture and wildlife sector for zoonotic risk monitoring. Now we come to multiple choice part of the presentation. Let's start with MCQ 1. A district health officer tracks monthly immunization coverage using DHIS2 data and compares it with annual targets. Which function is primarily being performed? Impact evaluation, routine program monitoring, process evaluation, surveillance, or economic evaluation?
B.
Yes, it is routine program evaluation. During an RDQA visit, a supervisor finds that 95 children are recorded in the vaccination register, but 120 are reported in the monthly DHIS2 summary. Which data quality measurement is most compromised? Timeliness, representativeness, accuracy, completeness, or stability?
C.
Yes, it is C, accuracy. It is accuracy. A maternal health program defines its indicator as percentage of pregnant women who completed at least 4 antenatal care visits during pregnancy. Which of the following best represents the appropriate denominator? Total women of reproductive age, total deliveries in the district, total pregnant women registered in the facility, total female population, total expected pregnancies in the catchment area.
C.
It is E, total expected pregnancies in the catchment area. A provincial health department conducts a midterm assessment to determine whether a TB control program has improved treatment success rates compared to baseline. This activity is best classified as formative evaluation, monitoring, surveillance, outcome evaluation, or process audit.
D.
So, yes, it is D, outcome evaluation. Yes, it is. In a dengue control program, the monitoring plan states that if the weekly case count exceeds 50 cases for 2 consecutive weeks, a vector control campaign must be initiated. This predefined threshold primarily supports cost effectiveness analysis, accountability reporting, decision triggered response, long term impact evaluation, or data validation.
A.
This is decision triggered response. So it is C, decision trigger response. Which of the following indicator is most appropriate for measuring program impact rather than output? Number of health workers trained, percentage of facilities submitting report on time, number of awareness sessions conducted, maternal mortality ratio, or E, number of antenatal care visits recorded. So it is about the impact, which is the very long term results rather than the short term results. So this will be maternal mortality ratio. Answer is D. A district consistently reports 100% reporting completeness every month, but field audits reveal many facilities submit blank forms. This suggests a weakness in data integrity, acceptability, sensitivity, external consistency, or timeliness.
A.
Yes, it is about submitting blank forms in the right time, but the data integrity is not there. It is compromised. A non-communicable disease program wants to determine whether its screening campaign has led to improved blood pressure control among diagnosed patients after 12 months. Which design is most appropriate? Routine monthly monitoring, process evaluation, economic evaluation, after action review, or outcome evaluation. So it is E. Yes, it is E. Which of the Following is a key difference between monitoring and evaluation. Monitoring uses indicator, evaluation does not. Monitoring is continuous while evaluation is periodic. Evaluation focuses only on financial accountability. Monitoring assesses impact, evaluation assesses outputs. Or E, monitoring is conducted only at national level.
A,
B.
Yes, it is B. Monitoring is continuous while evaluation is periodic, usually. So this is the answer key. This is the YouTube link where this video will be uploaded. And thank you very much for listening.